Okay, well, I think we'll get started. There'll be probably a few more people trickling in. Thank you so much for being here. My name's Emma Williams, and I'm here with my colleagues Lena Golob and Meva Vilad. We've got an interesting lineup of speakers for you today, but I wanted to just give you a little bit of background on this meeting series and why we're here today. So this event is being organised by the IAS Person-Centred Care Program, and our program is advocating for integrated, inclusive and responsive healthcare services that focus on the changing needs, priorities and preferences of individuals, and that empowers them to demand services that respect their identities. So what is this PCC Research Collaborative that we're talking about? This is a grouping of researchers, and the members will change and evolve over the years. And it was established last year at AIDS 2024. So the mission of the Research Collaborative is to work collectively and efficiently at a global level to fill evidence gaps around person-centered care for people living with or affected by HIV. And the collaborative aims to meet around 3 times a year through these virtual sessions to convene researchers, clients, and providers who are championing evidence generation related to various person-centered care topics. So this is really an ongoing journey that kicked off in 2021 to strengthen the evidence around person-centered care. So this journey kicked off in 2022. We had some seed grants. We had 4 seed grants in Africa and Asia, and those seed grants were to document good practice models for person-centered care approaches. We then had a 5-part stakeholder consultation series followed by a Delphi survey on the role of person-centered care within the HIV response and priority actions to achieve this at scale. We commissioned a systematic literature review, and of course, we launched this research collaborative. So this is the 3rd meeting of the research collaborative. The first one in Munich focused on identifying research gaps. And then we had a second meeting in February earlier this year, focusing on assessing the implementation of PCC approaches and different techniques to do that. So today we've reached on our little red journey there, we've reached our purple day today on the mental health and HIV theme. So that's what we're taking a deep dive on today. And later in the year, we'll be taking more of a focus on aging with HIV. We also have our conference coming up in Kigali in July. So just prior to that, in June, later this month, we'll be publishing our roadmap, our person-centered care roadmap for the conference. And the overall goal we're working towards is the publication of a research agenda for person-centered care. So these are just some examples of some of the outputs from this program. I'm not going to go through all these in detail, other than to give a shout out to Rodney, who's here, and his publications linked here. And also a shout out to our co-authors of our poster that will be published and presented in Kigali. So I think, yeah, we have Rena, I think, on the line from the co-author group, as well as Lena. So today's objectives are to understand the evidence base on PCC approaches to mental health and HIV, and also to discuss research gaps and priorities related to mental health and HIV to inform this research agenda and to spark potential future collaborations. So we do want to get you involved. That's why this is a meeting and not a webinar. So yeah, so we look forward to your contributions. I'm now pleased to hand over to today's moderator, Sharon Kruger. And Sharon is a psychologist and researcher at the Family Center for Research with Ubuntu, a clinical trials unit affiliated with the Stellenbosch University in South Africa. Her focus of interest is socio-behavioral studies, community engagement, and a participant-centered approach to HIV-related studies. So thank you, Sharon.
Hi, good afternoon, everybody, and good evening to some of you. I'm honored to be your moderator today. We've got a great lineup of speakers. After each speaker, we will allow you some time to interact with them by asking 1 or 2 questions. And then at the end of today, we'll have a further discussion where we'll get some reflections and broader discussions going with regards to the topic presented today. So if we can just move on to the meeting protocol, just to remind you to stay on mute unless you're presenting, or we'll call on you for comment. Use the chat to ask questions and share your thoughts on the points raised by the presenters. And if you'd like to ask a question or provide a comment during the discussion, just raise your hand and wait for us to call on you. So before I introduce today's speakers, I want to give you an overview of some recent published research on mental health and HIV. And in looking at that, we also explored some of the research gaps. But I think that it's important that we look why this topic is relevant and why it's important to look at mental health and HIV. Firstly, the studies consistently indicate that there are higher levels of mental health conditions among people living with HIV compared to the general population, and this is also for people affected by HIV. Commonly reported mental health conditions include depression, anxiety, suicidal ideation, post-traumatic stress disorder, stigma, and psychological distress. These conditions can lead to increase in alcohol and substance use. And we know that with mental health interventions, the research has showed that there's improved mental health symptoms, improved levels of stress and coping, and reduction of substance use, improved ART adherence, improved retention in care, improved health outcomes overall with regards to reduction in viral load, reduced sexual health behavior vulnerabilities, and reduced HIV transmission. Next slide. So we looked at research over the past 12 months, and from the, I think it was 145 research articles that were looked at, identified the main themes that we selected. And the research study showed that there was an intersection of social determinants of health, stigma, and HIV outcomes, that HIV trauma, and that there was HIV trauma in vulnerable populations. Mental health interventions for people living with HIV was a theme, and healthcare systems and other structural service delivery innovations was a further theme that we identified. If we delve a bit deeper into these, we'll look at the intersectoral or intersection of social determinants of health and stigma and HIV outcomes. And here we noticed that factors such as housing, food, insecurity, and transportation affected health outcomes. There was a strong connection between anxiety, depression, and HIV stigma. People living with HIV experienced higher levels of anxiety and depression, and this was especially linked to stigma and negative self-worth. We saw from the studies that stigma worsens mental health symptoms, and that there was a link between discrimination, stigma, and poverty, which created persistent disparities. So we also looked at navigating healthcare and provider mistrust, which reduced when there was a lack of discrimination in those services. With regards to the second theme that we identified, HIV trauma and vulnerable populations, we saw that post-traumatic stress, adverse childhood experiences, geriatric vulnerabilities were a common theme amongst people living with HIV. There was a high interest in PrEP, but a low uptake in PrEP services. Trauma-informed models were essential for intervention, and substance use and trauma histories elevate mental health burdens and disengagement in healthcare. For mental health interventions, we saw that cognitive behavioral therapies, self-help, peer-led, and peer-navigated interventions were quite effective, that client-provider relationships mediated quality of life, and that telemedicine and mHealth platforms such as digital health improved outcomes. And social support mitigates the effects of stigma and mental health systems, but specifically anti-discrimination and anti-stigma social support was important. With regards to structural healthcare and systems and other service delivery innovations, we saw that person-centered care improves mental health outcomes, person-centered care improves HIV prevention uptake. We looked specifically at community and academic partnerships, could make a difference in terms of implementation, and then studies also highlighted, again, digital platforms enable mental health and HIV services, despite provider shortages. So these were the themes that were identified from the research that we looked at. And what we will do now is, as you can see, that there's a complexity of issues, and we will allow time for discussion afterwards to reflect on these complexities and to see perhaps what is currently happening with regards to further research and identify gaps within the research that we looked at. And maybe there would be an opportunity for some collaboration as well in our discussions. Okay. Right, so we are now going to introduce our first speaker for today, Ngubete Atenchong. And Ngubete is a nurse and a reproductive health researcher. She's passionate about HIV healthcare and sexual reproductive health amongst displaced people. And she's committed to providing mental health care to people living with HIV, specifically using culturally appropriate techniques. So, Ngubete, I'm going to hand over you to tell us about the evidence that supports effectiveness of friendship benches to support mental health in people living with HIV.
So, good afternoon, good morning, good evening, everybody. So, as Sharon said, I'm Atenchong Ngubete, and I'm going to be talking today about the effectiveness of the friendship bench intervention. And I'm also going to go through a methodology that is proposed to help improve people living with mental health state community. So next slide. So the friendship basically an intervention that was proposed in Zimbabwe, Banda, and he proposed this intervention to kind of the rate of mental health issues in Zimbabwe after finding out that 30% of had mental health issues. The suicidal rate was twice as much as the regional prevalence. So in order to address this issue, he came up with an intervention where he used lay healthcare workers to deliver problem-solving techniques within the main objective was to ensure that mental health is integrated in the community, the reduction of stigma through this process to ensure provision of cultural appropriate care for people with mental health conditions. So, next slide. So essentially, the elements of the friendship bench includes problem solving, where the mental health, the person with the mental health condition has an interaction with the healthcare worker, and they focus on problem solving. So they define a set of SMART goals, where the person is going to walk through those SMART goals to ensure that the problem is being solved. So one good thing about this intervention is that it's culturally grounded. So it uses the culture, the lingua franca of the people to design where the people could actually easily understand and relate with the intervention better. So there's also a tight between the lay healthcare workers and the mental health professionals in the facility. And there's also a form of weekly support and encouragement for the people with the mental health conditions. And there are also group sessions that support where the people interact and share their experiences and other like income generating activities to boost their morals and welfare. Next slide. So as I has a set of process is to screen the person for the mental condition. So tools were used. So you have Shona symptom questionnaire and the PHQ symptom questionnaire assessed for depression, while PHQ-9 assessed for depression. So this questionnaire were culturally were adapted to the environment, so they were culturally appropriate. So that's another good thing about this intervention. So individual counseling sessions, problem identification and exploration. Then there was an action plan for the patient, which was guided by the lay healthcare worker, and there are follow-up sessions with phone calls and support group connections. Next slide. So these are basically the essential steps. So it's a program that takes a series of steps that goes for 6 weeks. So the person health condition goes for a period of 6 weeks. Like,
Nikubete, you're breaking up a little bit, so I'm just wondering if you could turn off your camera.
oh yes.
Thank you.
Okay, can you hear me? So I was saying through these steps in a period of 6 weeks. So through these steps, there's a required number of time that each person spend within a particular step. There's a required number of time as seen on the screen. So the next slide, please. We did a mini review to somehow assess of the friendship bench and 8 articles in basically to find out the effectiveness and identify gaps for this review. Next slide. So you may skip the next to the next slide. So these are the papers we review, and what we found out was that the friendship bench significantly reduced common mental health conditions. So, and it demonstrates effectiveness for short-term use. So that after 6 months, the effectiveness of the intervention was not significant. So people, the patients and the community members positively accepted this technique. So they have found trust for the intervention and for those delivering the technique. So it was acceptable to them. So it's a very effective task shifting techniques because it relieved the nurses and doctors and other high skilled workers of some of the interventions that maybe they could perform in their office. So it gave them some time to focus on highly advanced skills. So it also empowers the patient and even the lay healthcare worker with problem-solving skills. And it could be seamlessly integrated in the center, which is another very important advantage of this technique. But it is very, very acceptable for women and youth. So women and youth embrace the idea of the friendship bench approach compared to other demographics. Next slide. However, excuse me. However, there are some weaknesses or gaps with this intervention. So for long-term use, there is no significant effect on this depression and anxiety. So we see that it's within 6 months, depression goes down, but thereafter, there is no significant effect. So the people, men and youths, complain about had privacy concern. The intervention was basically where you put a bench out on the tree on some comfortable place and you sit and talk to the healthcare worker. So men and youth have privacy concerns with this intervention, which is also something we need to look at. And I didn't find any literature that spoke to the LGBTQ community and also to aging people as well. So it has mostly focused on women, youth, and adults and women, basically. So there is also one of the papers focused on youth mentor mothers and the PMCC program, and one unexplained, there was an unexplained decline in maternal child scores, which is very, very concerning because the women actually had a significant increase in their mental health scores, but there was a decline in maternal child interaction, which may mean that this intervention may actually focus more on the patient, but not on the environment or the patient's surrounding and the patient's welfare, or those things that interact with the patient, is of very significant concern. So another thing is the retention of the intervention itself. It's a very big issue. So one intervention actually stated that, one research stated that the intervention worked for some time, but sustainability was an issue. And at a certain point, the researcher also mentioned that the cost of implementing the program for a long time was actually also a problem. So most of the research also noted that there was no effect of ART adherence for those that did the friendship bench approach and HIV. So I want to believe that maybe because of the short intervention, the short time of monitoring within 6 months, they could not see an effect on ART adherence. So we need to explore further whether this intervention could really improve ART adherence. So this intervention has not been implemented in many African regions, in the West Africa, Central Africa, and the northern part of Africa. So it's something we still need to explore if it can work for these regions as well. And there's a need to develop robust pathways for this intervention so that it strengthens referral systems, strengthens strengthens sustainability of the intervention, and also make sure that the intervention is well grounded in the PHC system. So next slide. So the person for person-centered care intervention, we see that the friendship bench approach actually offers an opportunity for us to integrate person-centered care interventions for people living with HIV/AIDS. So most research has basically focused on in the clinics, and they have not, most mental health research have focused in the clinic, and they have not involved people to person-centered. So, but the friendship bench actually brings in a community-embedded approach that is culturally sensitive, and that can the WHO mental health integration goal. Next slide. So based on this background, we proposed a methodology that used the cross-sectional intervention design and a mixed study method to assess if an intervention that uses the PCC design and the friendship bench is going to improve the health outcomes of people living with HIV. So the inclusion criteria was for people, adults living with HIV 18 and above, but we want to exclude people with cognitive impairment and acute health conditions. Next slide. So we plan to measure socio-demographic characteristics. We also plan to measure the number of people living with HIV in the community that had mental health challenges or mental health conditions. We also plan to measure change in adherence and opportunistic infections within 3 months, 6 months, 12 months, and maybe thereafter. We also plan to assess care engagement by assessing the provider-client encounter through a developed instrument that we are going to develop and pilot. Also post-encounter feedback. After the encounter, the healthcare provider, following the intervention, we're going to have a post-encounter feedback. We're also going to design a tool to assess client communication, and also going to design a tool that will assess their involvement in the care process and care process. And we also hope to collect qualitative data using an interview guide to assess how, if this intervention is acceptable and the impact of the model to the peer HIVs in the community. Next slide. So based on all this I've said, I think there is a need for us to look at further evaluate person-centered mental health models like the friendship bench for people living with HIV in different countries. There's also a need for us to jointly develop cultural validated mental health screening tools and the mental health screening tools, and also PCC tools. PCC is really difficult because we will hardly ever find a tool that it assesses the PCC components, all the PCC components, and we need also make sure that these tools are culturally sensitive. So there's also a need for policy advocacy. We need to collaborate on working on policy briefs to promote PCC intervention and mental health integration in national HIV strategies. So thank you very much.
Thank you for that, Ngwebete. That was very interesting. I think what really stood out for me was that this is a person-centered care psychosocial intervention that really looks at being culturally grounded. And I don't know if there's any questions for Ngwebete. We can allow for 1 or 2 questions now. Maybe I can just start to ask, I think, did I miss, how often did they return to the bench for those interactions with health workers?
So the friendship, the guideline says it's a 6-week approach. So for the first intervention is after the screening, you are referred to the healthcare worker. So you interact with the lead health worker, there's problem identification, and then you try to build up your goals for the intervention. It takes a process of 6 steps. It's a 6-step approach that takes a period of 6 weeks. So when you identify your goals, the healthcare worker is going to call you to follow up on how you are doing, if you're meeting your goals, if you need further support. So it's just basically a continuous process. Yeah.
Thank you. So they return to the bench then on a weekly basis, or they set their goals and you follow them up?
Yes, they set the goals and you follow them up. Yeah.
Okay. All right. Are there any questions from anyone? If there's
Hello,
no
can I be heard? Hello, good afternoon. I don't know if
Hi,
I
good
can be heard.
afternoon.
Okay, my
Yes,
name is
you
Oyin
can.
Kachi Onamura. Yes, and I also work in Nigeria. In fact, one of my abstract was also submitted on mental health for key population. So I'm really interested in what she presented. She said something about gap in data for LGBTQ community, especially in Nigeria. I'm not so, I don't know, maybe she can throw more light on that, because I know there are a lot of papers that have been done around mental health, even on key populations. Key populations, which also part of the LGBTQ community in Nigeria. I really want to applaud her for the presentation and also for the approach. I think these are some things we can also look at integrating into the key population program. Well done. Thank you.
Thank you. So what I'm hearing is that you are echoing her finding that there's a gap for further research.
Okay,
Oh,
I
yes,
think
yes.
Yeah. So if I understood you well, Onyekachi, yeah. So can you hear me now?
We can hear
Can
you.
you hear me? Okay, so if I understood Onyekachi very well, he said I pointed out there is a gap on the LGBTQ community. So I was not referring to the general gap. So my scope is for the friendship bench and mental health and research. So I was pointing out that no research for the friendship bench or no intervention has been done for the LGBTQ community using the friendship bench approach, which is actually a concern, because we know with these people, they need support. They need support. That one-on-one support is really going to help them to open up, and try to meet their goals to recovery as well. So such an intervention may also benefit this community. So there's a lot of research out there about them, but interventions like this have not reached this set of individuals.
Thank you for clarifying that, Ngwebete. All right, then if we can move on to our next speaker, we call on Jessica Sales. Jessica is a developmental psychologist with expertise in cognitive and emotional development. She did her postdoctoral training in behavior science, and she's currently the co-director of prevention and implementation sciences at the Emory Center for AIDS and Research. And she's the director for Emory, the CFAR Implementation Science Hub. So Jessica will be talking to us about her work on trauma-informed care in primary healthcare settings. Hand over to you, Jessica.
Thank you so much. Good day, everyone. I know we're all spanning a lot of time zones, so thank you for making it today. As Sharon noted, I'm going to be talking to you about the readiness and capacity of HIV primary care clinics to provide trauma-informed care in the southern U.S. Is the context that I've been working in. So just to tell you a little bit about myself, as mentioned, I'm a developmental psychologist by training, and the year that I started graduate school was in 1998, and that year was the year that the seminal ACEs study was published. So for those of you that don't know this study, ACEs stands for Adverse Childhood Experiences, and a team of researchers from Kaiser Permanente and CDC surveyed approximately 17,000 Kaiser-insured adults about their exposure to abuse, neglect, and household dysfunction as children. And what they found was that ACEs were really common, and the more that you experienced as a child was related to the higher likelihood of having a host of behavioral, mental, and physical health issues into adulthood. Next slide. However, trauma is more than just adverse childhood experiences. It can happen at any time in the life course and still have detrimental effects. So a common definition of what constitutes the traumatic experience is one put forth by SAMHSA, which is the Substance Abuse and Mental Health Services Administration in the US. And they state that traumatic events are events or circumstances experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on that person's functioning and mental, physical, social, emotional, and spiritual well-being. Traditionally, this has encompassed experiences that are privately experienced, such as child abuse, sexual assault, intimate partner violence, traumatic grief and separation, but it also includes experiences that are publicly experienced, like exposure to community violence, school violence, bullying, as well as military trauma and natural disasters. Another type of trauma that is more recently included is referred to as a collective trauma. Collective trauma refers to the psychological reaction to a traumatic event that affects an entire group or community. And in the context of HIV, the diagnosis of HIV can and is often reported by patients as a traumatic experience. Next slide. And it's unfortunate, but it has been well established that trauma across these various types of interpersonal and community level trauma are highly prevalent among people with HIV, and they are more commonly experienced by people with HIV than those without. Next slide. But why should practitioners want to address trauma in HIV care settings? Because like the ACEs study found, experiences of trauma among people with HIV is associated with a host of adverse physical, behavioral, and psychological outcomes. And for example, a meta-analysis estimated that 30% of women living with HIV in the US had PTSD, which is 5 times higher than the rate projected in women in the general population. Yet PTSD goes largely undetected and untreated, even for those engaged in HIV care, highlighting a missed opportunity for treatment for these women. Those with trauma histories also experience higher rates of depression, anxiety, and suicidality, as well are more likely to engage in problematic substance use, perhaps as a means to help them cope. Next slide. So beyond the fact that many people with HIV have experience with trauma, oftentimes multiple traumas, making trauma a salient factor in their lives, and I've shared that this can impact multiple health outcomes. Another reason to consider addressing trauma in the context of HIV care is that HIV clinics, particularly Ryan White supported HIV clinics, so they're federally supported clinics in the US, often are exceptionally well positioned to address patients' trauma-related needs. This is because the provider and staff working in Ryan White HIV clinics have usually established relationships and rapport with their patients and are seen as trusted sources of care. Feeling supported and connected is a key to building resilience. And further, these providers are trained to ask difficult questions in a respectful and sensitive manner. Also, the infrastructure of the Ryan White program, and oftentimes even co-location of services in the same building, facilitates easier access to multiple types of care that individuals with significant trauma-related needs might benefit from, such as mental health, substance use management, and access to social services like safe housing, legal support, or peer support opportunities. Next slide. We also know that trauma can impact those who care for people with HIV, and that sometimes working every day with people who have challenging lives and high rates of trauma can take a toll on care providers and staff. There are a couple of ways that this can happen. So vicarious trauma, also known as secondary trauma, occurs via indirect exposure to traumatic events, often through hearing firsthand accounts of people's traumas. People in the helping profession, like HIV care providers and staff, may be at risk for vicarious trauma. Now, vicarious trauma can lead to various levels of burnout and compassion fatigue, which can impact higher rates of turnover in many organizations that serve people with HIV. Importantly, people in the helping professions like HIV care are drawn to the work for personal reasons or their own personal experiences, and this might increase their risk for vicarious trauma. So given the multiple levels of vicarious trauma, compassion fatigue, and burnout that can exist within the HIV care workplace, workforce wellness and self-care among providers and staff is essential to providing high-quality HIV care. Next slide. So what can clinics do to address trauma and the potential vicarious trauma that their staff and providers might experience? The use of trauma-informed care practices in places where people are seeking HIV care can help. It can be an effective way to begin to address this widespread impact of trauma on the health of those in the healthcare system. So trauma-informed care, it's a strength-based organizational approach that is grounded in the understanding of and then responsiveness to trauma. It's an approach that emphasizes physical, emotional, and psychological safety for both patients and their care team, as providers and staff working with survivors can experience vicarious trauma or have their own trauma histories. Trauma-informed care is often described as the 4 R's: realize, recognize, respond, and resist re-traumatization. So what this means is that trauma-informed clinics ensure that all individuals working in the clinic have a basic realization about trauma and its impact on individuals. This includes everyone from the front desk to the checkout and every individual encountered in between. Trauma-informed clinics are places where all individuals on the care team can recognize the signs and symptoms of trauma, and they can respond by fully integrating knowledge about trauma into their policies, practices, and procedures. Also, because clinical practices and procedures, especially those in medical settings, may unintentionally re-traumatize patients, trauma-informed clinics commit to and actively work to resist re-traumatization through building cultural competence and capacity among the care team to effectively respond to trauma and patients' trauma reactions. Next slide. So trauma-informed care is an evidence-based approach that is endorsed by SAMHSA. SAMHSA also, because of this, has worked quite extensively to provide a blueprint for agencies to help them provide trauma-informed care. Specifically, they focus on strengthening or attending to 5 key domains. These domains include supporting staff development. So this would be engaging in training and promoting and providing opportunities for self-care for staff and providers. The second domain is creating a safe and supportive environment. This is not only focused on establishing a physically safe environment, but also in an environment that is emotionally and psychologically safe as well. The third domain is assessing and planning services. This is where we think about integrating opportunities to screen and identify individuals with trauma or PTSD, and developing service plans for those individuals and connecting them to the appropriate care as needed. The fourth domain is involving patients. This kind of cross-cuts every domain, and it's involving patients in the selection of services and also involving patients as peer advocates, as well as allowing multiple ways in which the patient's perspective and voice can be heard and realized in clinical care. And the final is adopting policies. And this is where clinics intentionally look at evaluate their policies and create policies that address issues of safety, or revise and review policies regularly to look for and minimize points for re-traumatization. Next slide. So although trauma-informed care is evidence-based and seems to be a great potential fit for HIV care environments, we know very little about the extent to which Ryan White HIV clinics are providing trauma-informed care across these 5 domains of practice. Further, we know very little about the barriers and facilitators for Ryan White HIV clinics for adopting and implementing trauma-informed care practices across domains. So with that in mind, we conducted a mixed method study among Ryan White HIV clinic providers, staff, and administrators across the southeastern US. And we focused on the southeastern US because that is the epicenter of the US HIV epidemic. So we wanted to do this mixed method study to begin to fill these research gaps. Next slide. So first, we conducted a survey among 321 staff and providers working in 46 unique Ryan White clinics across the southeastern US to better understand where they were at with providing trauma-informed care. And what we found was that most were performing well on many of the domains that I just talked about, but most noted that training and staff support were the place where they were lacking the most in those domains. And we just finished conducting a follow-up survey of approximately 100 Ryan White care providers this past summer, and we learned that about 50% had reported attending a trauma-informed care training, and most that had attended training felt that helped them have a strong sense of what trauma-informed care was. But they felt like they walked away with lower ratings on their confidence to be able to apply trauma-informed care in their roles in clinics. So even though training is becoming more familiar in these settings, it's maybe not completely adequate for helping them implement and practice. Next slide. So in addition to the survey, we conducted interviews with 37 staff from the 46 organizations. The aim of the qualitative analysis for those interviews was to examine the determinants of trauma-informed care implementation within Ryan White clinics in the southeastern US. So trauma-informed care is a complex intervention requiring many different changes within the clinical setting, such as changes to clinical services, changes to the physical space, and changes to provider practice. So given the complexity of trauma-informed care, we wanted to identify influential factors that served as facilitators for each of these core SAMHSA trauma-informed care domains. Specifically, we focused on 3: the staff support and development domain, safe and supportive environments domain, and the assessing for trauma and linkage to services domain. The first domain of trauma-informed care, staff support and development, refers to the promotion of provider and staff well-being and self-care, as well as the promotion of provider and staff trauma-informed skills development. Based on participant discussions through these interviews, implementation of staff support and development was facilitated by the constructs of access to knowledge and information from the Consolidated Framework of Implementation Research. It's also facilitated by leadership engagement, clinic culture, and tension for change. And I'm going to go through and talk about these things on the next slide in more detail. The second domain of trauma-informed, oh, can you go back to that slide? Thank you. The second domain of trauma-informed care refers to the clinic environment and how staff promote both emotional and physical safety for their patients. Participants discuss how a safe and supportive environment was facilitated by their clinic culture, availability of particular resources, including staff time, and networks and communication. And finally, the third domain of trauma-informed care refers to the methods clinics utilize to screen, assess, and link patients to necessary trauma services. So trauma services include housing placement, legal, consultation, social work, mental health, and substance use services, which can be provided either on-site or through external referrals. Implementation of this domain was facilitated by having access to knowledge and information, available resources to the clinic's disposal, having strong networks and communication, and having strong external partners. Next slide. So with those results in mind, we created a roadmap of implementation strategies to facilitate the adoption and implementation of each of these domains for Ryan White HIV clinics in the Southeast. The first domain of trauma-informed care, staff support and development. This is a requisite first step of trauma-informed care implementation, since providers need to develop trauma-informed care skills, as well as address their own stressors prior to supporting their patients. So to facilitate the adoption of staff support and development, participants identified 4 key determinants, the ones I mentioned on the last slide: leadership engagement, culture, attention for change, and access to knowledge and information. So with that in mind, we map these to implementation strategies, specifically implementation strategies that may enhance the uptake of this domain in Ryan White clinics include offering leadership incentives to promote trauma-informed care trainings and staff support to increase leadership engagement. We also note the revision of clinic mission statements and priorities to focus on trauma-informed practices for both patients and providers would help address the clinic culture around supporting trauma-informed care. Utilization of organizational change teams to raise awareness of provider burnout and develop priorities for trauma-informed care would help to address the attention for change that was expressed by many of our participants. And the provision of trauma-informed care training for all staff and providers in the clinic would address and facilitate access to information and knowledge. So after implementing this foundational domain of trauma-informed care, clinics should then consider establishing a safe and supportive environment. Contextual determinants that facilitate the implementation of safe and supportive environment included culture, available resources, and networks and communications. Implementation strategies that target these determinants include providing opportunities for patients to inform decisions and engage in shared decision-making, allocating funding and time for clinics to remodel or reconsider their physical space to address the available resources facilitator, as well as strengthening patient and provider and patient-peer relationships to increase networks and communication in the healthcare system. Next, clinics should consider implementation of the third domain, which was assessing for trauma and linkage to services. Participants expressed that they needed strong networks and communication within the clinic, as well as strong external partnerships to implement this domain. To strengthen these determinants, clinics may consider adopting multidisciplinary care team approach to trauma treatment to address the networks and communication construct, and developing or formalizing partnerships with external trauma support organizations and providers to address and strengthen external partnerships. Participants also expressed the need for access to knowledge and information, which can be strengthened by training on methods to screen for trauma and refer patients to trauma services. Trauma screening in HIV care clinics in the US is typically very limited, often focusing only on the identification of intimate partner violence. suggesting a need for training on how to screen for and respond to a broader range of traumatic experiences that are common among people with HIV. So lastly, participants believe that available resources like trauma-trained mental health professionals and on-site trauma services were important for implementation of Domain 3. But in under-resourced settings like Ryan White clinics, clinics may consider utilizing telehealth mental health services or referring patients to external trauma services if they are unable to fund or provide services on site. Next slide. So in conclusion, Ryan White HIV clinics across the southeastern US are indeed employing many trauma-informed care practices. But training and workforce development is a key and foundational gap in trauma-informed care implementation for HIV care settings in the US. And though multiple strategies are necessary to facilitate the adoption and implementation of trauma-informed practices across domains, we are hopeful that the roadmap that we created will help HIV clinics provide this much needed trauma-informed care for their patients and to support workforce wellness. With that, I'll end. Thank you so much.
Thank you, Jessica. That was very interesting, and I don't doubt any of us question that trauma-informed care is essential in addressing HIV needs for people living with HIV. Are there any questions for Jessica?
I did have one question. Thank you for the great presentation. I was wondering, since you mentioned how you saw that although there was training in trauma-informed care and people were aware of the basic principles, but there was low confidence in implementation. Correct me if I'm wrong and I'm misinterpreting that. What do you think would then need to change or be added in terms of the elements within trauma-informed care trainings to improve confidence in actually applying it?
Yeah, I think that what we have learned is that a lot of the trauma-informed care trainings are things that people attend at like a 50-minute session that is very general and provides a high-level overview of what trauma-informed care is, and also educates on the need for trauma-informed care. So they get a basic understanding of that trauma is prevalent, that trauma has an impact across these outcomes, but there's not a lot of intentional training on how this relates to their particular role and what they could be doing to integrate and change their particular roles. And so I think more robust training, acknowledging that this is an organizational level intervention that impacts all the individuals in a system. So it's not just a 50-minute one-off training. It's a little bit more intensive training that's going to be needed. And then the other thing that that we have learned in some subsequent studies is that, and probably you all know this, sometimes trainings are great, but they don't get the job done in integrating this into workflows. And so that's really where like that creation of and leadership buy-in to devoting intentional time and maybe creating a change team or someone that represents each of the units within a clinic to really think about what they could do within their workflows to integrate trauma-informed practices and to revise maybe some of the policies and procedures that they utilize in their own units or in their clinics is also going to help make that training more actionable for folks in reality. So I would say it's the training needs to include skills building instead of a lot of the trainings that that people have reported going to, which just tend to be more educational, informational.
That makes sense. Thank you so much, Dr. Sales.
Just to follow up, we created a 6-part training that we're doing right now and testing to see how that might create to like getting down into the skill development. And we make individuals then think about like how this relates to their own role at their clinic, and they write a personal action plan for each of the elements of the training that they go to sort of think and connect, even though these are 6 50-minute trainings, to get it a little bit more embedded in thinking about their own particular role and how they could apply each of the topics that we cover. Oh, so have we tried, I see a question in the chat, have we tried the training with peers? We have not, but we just are waiting, fingers crossed, for funding to do this with peer navigators in particular, and actually to strengthen the linkage from external testing sites into HIV care settings. So check back with me in about a year and we'll hope to have some data on that specifically. But excellent question. And actually, when we talk, I'm not even presenting the work we do with the patient side, which they find trauma-informed care highly appealing for a variety of reasons. But they very, very much advocate for a lot of the steps in terms of screening and intervention to be peer-led. So I think peers are a critical piece of this engagement.
Thanks, Jessica. I see Lillian also echoes that was a great presentation, and we really value your input in trauma-informed care. And I support that ongoing support for those that we train in trauma-informed care is needed, that to build skills to support them. You talked about compassion fatigue. It's really important that we offer that support. And I know that in a country like ours, we know that the referral doesn't work very well when we refer patients out for trauma-informed care, So I liked your idea of telehealth services or having perhaps a lay counselor on site available.
Thank you. Thanks for the opportunity to share with y'all today.
Thanks, Jessica. All right, we're over to our next speaker, and I want to introduce to you Jeremy Ross. Jeremy is the research director at AMFA's TREAT program in Asia, and that's in Bangkok in Thailand, and he looks at implementing clinical epidemiology and mixed method research on HIV clinical outcomes, but with a special interest in HIV prevention, counseling, testing, care and treatment through advocacy, capacity development, and technical support. So Jeremy, with that, I hand over to you to talk to us about mental health care for people living with HIV and your research from TREAT Asia.
Yeah, thank you, Sharon, for the introduction, and thanks for the opportunity to talk to you today about TREAT Asia's research around the integration of mental health care for people living with HIV. Next slide, please. So for those that are not particularly familiar with the TREAT Asia network, it's a collaborative network of clinics, hospitals, research institutions, and civil society that works to ensure safe and effective delivery of HIV treatments to adults and children across the Asia-Pacific region through research, education, community advocacy, and policy activities. Our research is conducted through 21 adult and 18 pediatric clinical sites in 12 countries across the region. And this research work is funded primarily through the US National Institute of Health funding. Next slide, please. So before I kind of focused a little bit on our current and ongoing research around the integration of mental health and HIV clinical services, I want to kind of take a step back and talk a little bit about what brings us to that point and what drives our interest in research around the integration. And the first point to mention is the high prevalence of mental health disorders amongst people living with HIV. So the data in this slide is data from a study that was completed some years ago. It's called the Stigma, Substance Use, Depression and Disability, or S2D2 study that TREAT Asia conducted. And in this study, we found that amongst over 860 adults living with HIV, 19% had moderate to severe depressive symptoms using PHQ-9 screening. Next slide, please. So the TREAT Asia network collaboration has conducted similar studies on different populations. So this data is from a study focusing on adolescents living with HIV in care at 2 TREAT Asia pediatric HIV centers in Thailand. And again, 11% had significant depressive symptoms, 7% had anxiety, and 14% had suicidality at baseline. Next slide, please. And another reason why we're interested in assessing the integration of mental health and HIV care is because of the substantial negative impact of mental health disorders across the HIV care continuum, ranging from increased risk behaviors and higher risk of HIV acquisition to delayed HIV testing, linkage to care, ART initiation, poor HIV care retention, poor antiretroviral therapy adherence, and lower virologic suppression. Next slide, please. So this is data, again, from a couple of analyses from our S2D2 study, illustrating in an Asia-Pacific population of adults living with HIV that suboptimal antiretroviral therapy adherence was associated, significantly associated with moderate to severe depressive symptoms, and that medium to high risk sexual practices were more likely amongst study participants with moderate to severe depression. Next slide, please. So it's not just HIV clinical, negative HIV clinical outcomes that mental health disorders are associated with. There's a multitude of other negative outcomes. This echoes some of the data that Sharon showed, but associations with mortality, stigma, quality of life, and frailty. And some of these references are focused primarily on Asia-Pacific populations. Next slide, please. And again, an analysis from 753 S2D2 study participants that screened positive for either depression or substance use that illustrates an increase in mean disability and a decline in mean quality of life scores were found with increasing severity of depressive symptoms. Next slide, please. The significant kind of burden and impact of mental health disorders amongst those living with HIV, particularly and including in the Asia-Pacific region, is certainly compounded and compromised and exacerbated by the limited financial and human resources that are devoted towards mental health care. So mental health care funding and the mental health workforce per 100,000 population are well below the global average in the Southeast Asia region. Next slide, please. And it's also important to note that levels of integration of mental health screening and treatment within HIV clinical settings remain very limited. So the data on this slide is from the 2018 and 2020 assessments of HIV site clinical capacities in clinics across the IDEA, or the International Epidemiological Databases to Evaluate AIDS, global collaboration. And in these analyses, Asia-Pacific sites had very low rates of screening for mental health disorders. So, for example, only 43% screened for depression, only 11% for PTSD, and lower proportions of sites also included and provided mental health disorder treatments, including counseling and medication for various mental health disorders that included depression, anxiety, and PTSD. Next slide, please. So this brings us to one of our current and ongoing projects, which is the Mental Health and HIV Service Integration, or MINT study. This is a mixed methods implementation effectiveness hybrid study that we're implementing at 4 sites in Malaysia, Philippines, and 2 in Thailand. The objectives of this ongoing study are to identify patient and provider level barriers and facilitators to the implementation of mental health screening and linkage to care interventions in HIV clinical settings, to then develop and implement optimal mental health screening and linkage to care interventions and approaches, and finally to assess the implementation and effectiveness of those mental health screening and linkage to care interventions and approaches at each of the study's participating sites. Next slide, please. So this study has a pre-implementation phase, which we've completed, that focuses on identifying barriers and facilitators to mental health screening and linkage integration. There's a validation phase, which has also been completed, which involved the validation of the mental health screening tool that we used in the study, which is the EMW tool, and this is a 13-item multi-disorder screening tool. And then there's an implementation phase where sites implement their site-specific mental health screening and linkage interventions, and a post-implementation phase where we assess the feasibility, acceptability, implementation, and sustainability of site-specific mental health screening and linkage interventions. Next slide, please. As I mentioned, the study is ongoing, but we do have initial analysis from various phases of the study that I think are worth highlighting to this group. The data in this slide is from a pre-intervention qualitative analysis of facilitators and barriers to the integration of mental health screening and linkage to care at one of the study sites in Thailand. And in this analysis, both clients and healthcare providers emphasized the need to integrate comprehensive mental health screening and linkage interventions for the study population, and also identified several barriers to integration, including stigma both towards mental health and HIV positive status, a lack of mental health healthcare specialists, and concerns around associated screening and linkage costs. Next slide, please. So this slide is just a summary of an analysis that will be presented at the upcoming Asia Pacific AIDS and Co-Infections Conference later this month in Tokyo. So this data is not really for further dissemination, but broadly speaking, this is an analysis of implementation of the mental health screening and linkage to care intervention at the study site in Malaysia. And it really highlights the importance of engagement with the administrative staff of the clinic, the HIV nurses, and psychiatric staff in order to successfully implement the screening and linkage to care intervention, and emphasizes that implementation requires a continuous process of tailoring and adjusting implementation strategies that address identified challenges at ground level as they emerge. Next slide, please. Again, another analysis from the study that will be presented at the forthcoming Asia Pacific AIDS Co-Infections Conference. This is the analysis of implementation at one of the study sites in Thailand. And what's interesting to note is that of the 66 participants that screened positive for a mental health disorder, a very high proportion declined further mental health support due to concerns around time consumption, additional clinic visits, and associated treatment costs. It's also interesting to note that of those that were successfully linked to care, a very high proportion preferred or selected in-clinic referral options for linkage to mental health care. Next slide, please. There's another Treat Asia program that I'd like to highlight. This is an ongoing NIH-funded program. It's called Chimera. The objectives of this program are to develop HIV and mental health implementation research capacities in 4 Asia Pacific countries: Thailand, Philippines, Malaysia, and Cambodia. As part of this program, or within this program, program participants, or fellows as we call them, develop and conduct implementation research studies that assess various mental health and HIV integration approaches. So, for example, task shifting or collaborative care models. And broadly speaking, quite a number of analysis and data has been generated from this study that broadly indicates the feasibility and acceptability of these various integration approaches by different types of healthcare workers for different subpopulations and in various different HIV clinical settings across the region. So just to conclude on discussing and considering some of the research gaps around mental health and HIV, and these particularly apply, I think, to the Asia Pacific region, which is where Treat Asia is based. So I think it's fair to say that we have a fair amount of translated and validated screening tools for mental health disorders. That there is evidence of effective mental health disorder interventions for people with HIV and associated populations, and there's a fair amount in terms of policy and guidelines and tool support for the integration of mental health care in HIV clinical settings. I mentioned previously the EMW tool, which was a screening tool that we used under the mental health integration study that we're currently implementing. This is a multi-disorder screening tool, and I think there's a substantial scope for further research on the use and implementation of multi-disorder screening tools across the region, particularly in the context of, the constrained resources that I talked about, the desire and focus for task shifting, and also the fact that substantial proportions of our populations have multi mental health comorbidities. There's also a substantial scope for more research around prevalent mental health disorders other than depression. I think it's fair to say that the body of research focuses very much on depression as a specific mental health disorder and less so on things like anxiety and post-traumatic stress disorder. There's also a need for research around the impact associations and relationships of mental health disorders still with certain HIV outcomes, for example, retention and virologic suppression, where the impacts and associations are perhaps less clear than they are, for example, with poor antiretroviral therapy adherence, with other health outcomes such as mortality and relationships with other non-communicable diseases, and associations and relationships with other outcomes such as stigma and functional outcomes such as frailty and disability. Next slide, please. But a particularly important
Jeremy,
research.
if you wrap up.
Sorry? Yes, sorry,
just
last
to
slide.
wrap up.
Last slide. A particularly important mental health and HIV research gap is the need for implementation research to inform the integration, adaptation and scale up of mental health services within HIV clinical care. And I feel this is probably one of the most important areas. And certainly if we are to achieve targets such as those outlined in the Global AIDS Strategy, that 90% of people living with HIV are linked to people-centered integrated services for mental health and other services. Thank you.
Thank you. Thanks for a great talk. And I think that you highlighted definitely that there's an increase of mental health conditions and perhaps a concern that adolescents are declining support services. And perhaps that's something we can explore in our discussion. Thanks. I'm going to, if there's no questions, or I can ask you just to hold the questions, and then I'm going to introduce our next speaker, Ines. And then we will take the discussion questions at the end of Ines's presentation. So Ines Aristocri is the director of the Interdisciplinary Research Division. And Ines, you need to say your organization's name, the Foundation of USPED. In Argentina. And her focus is specifically on understanding psychological and structural factors that underlie health equities and affected healthcare. So I'm going to hand over to you to talk specifically about your health strategies for trans people and sex workers in Latin America.
Mm-hmm. Okay, first of all, thank you very much for the presentation and for the invitation to share with you our work. I work in Argentina, just down there in the south. And we mainly we have been working sorry, I cannot move with sorry, I'm just trying to get the here. So over the last decade or more, we have been working specifically with transgender and people and sex workers. And today I will be sharing or focusing in the result of 2 cohorts that we have and on the EPIC program. The EPIC program was community-led research that was conducted by 79 different community organizations in 32 countries It was coordinated by Coalition Plus. And the idea was to understand the impact that the pandemic has had in key populations. So it involved the 10 different languages. It was a huge work with quantitative and qualitative methodologies. And the interesting point was that in each country, the communities decided which type of methodologies they wanted to do and which type of studies they wanted to implement in their own country. So in Argentina, we focus in sex workers. And this type of work that we do, even as we do research under a community-based participatory research. So we don't not only engage with communities to consultate them, but we have a community engagement team in our research team. And we work in collaboration with organizations and with the community inside our team. And in this way is that we hold two big cohorts, one with 500 transgender and gender diverse people, and one with 200 sex workers, cisgender and female sex workers, cisgender and transgender. And they are very comprehensive cohorts because people actually go on annual visits where they have a medical consultation and also psychosocial interviews with trained professionals. So, and some of the questionnaires are actually conducted by peer members of the community. What we know is that a third of our cohorts basically mentioned that they had when they arrived and met mental health needs. And what we have found is that in those who actually needed to go to mental health services, but they didn't get them, were those who actually consume a lot, have issues with substance use, not only for recreation, but also it was linked to their work, like sexualized drug use. And they have also problems with alcohol. And the other thing is that, and these problems usually were more frequent among, I will show in another one that they are more frequent in more transgender samples. But the other thing that we found is that those who actually have their unmet needs on mental health were those who reported discrimination by healthcare system in the last year. So we also know from other studies that 40% of participants from our cohort avoided going to healthcare services just to because they fear to being discriminated for being sex workers or for being a transgender person. And in this study that was mainly with transgender people, what we've seen is that those who actually have more problems to access mental health needs were those with higher levels of stigmatization, both internalized and enacted stigma based on their gender identity. Sorry, but my English is not good today. Well, we asked participants about their mental health symptoms in the last month, and when we compare cisgender and transgender sex workers, what we've seen, as most of you have mentioned before, is that around 50% of the sample just suffer from stress, anxiety, but also loneliness and depressed moods. Sometimes there are no differences between cisgender and transgender individuals. However, the level of stress was higher among transgender sex workers. And when we ask and explore deeply about substance use, usually transgender people reported hazardous drinking or problems related with alcohol more frequently than cisgender women. But one of the things we also have in our country is not only that cannabis is, depending on the sample you actually take, but maybe half of the population smoking cannabis, we have among transgender women high levels of cocaine consumption, especially in the context of sex work. And sorry. And as you mentioned before, one of the issues that we may have with sex workers and one of the things, not only with sex workers, but with key population, is the high levels of emotional, physical, and sexual abuse during childhood. For our samples and our cohorts, it's around 50% of the samples reported sexual abuse during childhood. So this linked with Jessica's comment on the impact it will have in their future health. So
Inez, not to rush you, but just time to wrap up for us.
Yeah, sorry. So what we have seen is that also is not only when we talk about HIV or risk of HIV, particularly in this population, is that we have to consider like social determinants of health, because we have half of our population with food insecurity, low levels of education, unstable housing, working, especially sex work in the street, which actually also expose them for higher levels of violence. And also among those who have HIV, we will see these structural barriers having a role on that, but also, for example, how the injection silicones, liquid silicones that they use to get gender affirmation, it will be also like a risk, another factor associated with higher rates of HIV, but it works in like a protective factor, having access to a proper gender affirming hormone therapy. So what we have found in general is that when we measure when we explore the role of different type of discrimination or stigma on sexual risk behavior, when we did that was not PrEP on the market, at least in our country. So when we see that was not stigma and discrimination rather than having an impact, but they do have an impact on mental health, and in that way, going through that path, they will have an impact on risk behavior for HIV. So basically what we know is that if we want to work with care or prevention of HIV, we will have to integrate mental health in a more accessible way, as you have been mentioning before, just trying to expand the possibility of integrating easily screenings, but also what we have tested with some with these models with Más por Nosotras is the idea of testing at very basic level, and if we get positive results on mental health, just having a referral. But what we notice is that the role of the community is quite important. So our proposal is to keep working on developing interventions where the community is trained to work with trauma-informed, making these screenings, and then working on the referrals. And for the referrals, as it was mentioned before, trained professionals with trauma-informed care and also gender-affirming care that will be needed for that. We know from
Thanks,
our
Ines.
country, what we know from our country, just the last thing to say, is that the legal context was quite important for us. And at this moment, some things are changing, and that's like a big challenge in terms of how to care for right-based inclusive approaches for this population. Thank you very much.
Thank you, Ines, and sorry for rushing you. We've run out of time. I think that it's been wonderful listening to all the different presentations today and really seeing that there are people out there working on different aspects of mental health and HIV. So we're going to open it up now to discussion. There will also be further opportunity at a later stage. Emma indicated that she'll send out a survey. So if you don't have time for discussion today, you will have an opportunity to voice some of your questions or concerns, or maybe share some of your work that you're doing. But I'm opening up for questions now. So firstly, we want to look at, have the studies and the research that's out there on mental health adequately considered the specific intersectional needs of key populations living with or vulnerable to HIV acquisition? And then what is the status of current research on person-centered mental health interventions and treatment strategies for people living with HIV and experiencing mental health issues? And I think I saw in the chat there's some opportunity for collaborations on topics. And then I'm going to leave the last question for now. So maybe to open up to discussions. I think, Jeremy, you also highlighted some of the further research that is needed with regards to mental health and HIV. And I think that echoes what we saw earlier on with regards to the themes that were identified.
Yeah, Sharon, I mean, certainly from my perspective, it's I mean, implementation research in this area is a key area of importance for research. I mean, it's, we often have evidence and we do have evidence of interventions and their effectiveness amongst populations either living with HIV or key populations. And I'm certainly speaking from the context of the Asia Pacific region, but what we don't necessarily have is how to translate and implement effective interventions in the various context and clinical settings that we have across the region, and something that is effective somewhere else might not necessarily be able to be kind of just lifted and stuck in a different clinical setting and expect to be as effective or effective in the same way. So from my perspective, that's why we focus very much on implementation.
Thanks, Jeremy. Thanks. And I think with that, we won't have time for further.
That was again around sort of look disorder screen tools. Yeah.
Sorry, Jeremy, I spoke over you there. There was a break in communication. But I definitely echo implementation research. And I see Ines is saying that's culturally adapted is needed. So I'm going to hand back to Emma now, just to close our session for the day. And as I mentioned, there will be further opportunities through survey to talk about research that you are doing or suggestions, or if you want to collaborate. So I thank all the speakers, and Emma, I hand back to you.
Thank you so much, Sharon. And I'm sorry that we ran out of time, but these presentations were absolutely fascinating. And I think there was a lot of engagement already in the chat. So yes, we'll absolutely follow up with a survey Please reach out if there's, particular connections that you want to make. That's what we're trying to do here, is to make sure that you can all connect and continue to collaborate in this important topic. So we also wanted to just highlight some of the activities that we're organizing at the upcoming conference in Kigali. So we'll be having a session focused on the future of person-centered HIV, and also sharing that roadmap in a poster presentation. We'll also be having a networking dinner. So if you are coming to the conference, do let us know. And that roadmap that I already mentioned. And then I just wanted to wrap up today with a thank you to all our speakers, and to Gilead, who is our sponsor of our program. So thank you so much, everyone, for being here today. And we'll be sure to make sure these slides and recording are uploaded quickly and shared with you along with that survey. Thank you
Thanks,
so
everyone.
much.
Have a great evening and afternoon. Bye.